Thank you for joining us for the next rendition of the ASES Virtual Journal Club. Tonight is an extra special night for many reasons. Our good friend Eric Wagner just had another child, so we have a special guest with Joaquin Sanchez-Sotelo, our former president of last year, joining as a guest moderator, which is awesome because he's going to ask the hard-hitting questions of our awesome panel. Mark Morey from Mayo, Mike Goshak from Emory, and Matt Ramsey from Rothman. They need no introduction, but they are the world's experts in elbow. And hopefully we have some good articles and some good content for you tonight. So maybe, Steve, we could play the Smith and Nephew intro.
I think we're going to do the Mastering the Elbow.
Okay, sorry about that. So before we get into the Smith and Nephew intro, Mark, do you want to talk about this awesome Mastering the Elbow course that's coming January 9th, 10th in Las Vegas?
Sure. So this is a great course. Graham King and I are running the course and have put together a really nice agenda with some really leaders in elbow trauma, and it's a huge help, I think, to especially a young surgeon who has to take call and has to take trauma call and take care of, some of these elbow problems. And in the first year of practice, you can really cut your teeth, but you can also make, a name for yourself if you understand the elbow. And it continues to be a bit of a black box for a lot of people. So we hope to demystify the black box of the elbow during this course, and we're very excited about it and hope that you can join us in January in lovely Las Vegas.
Okay, awesome. It's going to be a great course, and hopefully we could demystify some of the elbow tonight too as a prelude. So, all right, let's do it. Let's play the intro.
Good evening, everyone, and welcome to the ASES Foundation webinar series. I'm Scott Gunn, Vice President of Shoulder Marketing and Sales at Smith & Nephew. As the sole sponsors of this series, we're thrilled to have the opportunity to introduce you to Smith & Nephew and our innovative product portfolio. For over 100 years, Smith & Nephew has been at the forefront of medical technology, committed to improving lives through our pioneering solutions. We're excited to share our latest advancements in shoulder arthroplasty and sports medicine. Our team of experts have been focused on providing you options throughout your patient's continuum of care with cutting-edge products like Regeniten, a bioinductive implant that redefines biologic healing for rotator cuff tendon growth, and the elegant ATOS shoulder system, which embodies stability, simplicity, and flexibility. ATOS is a streamlined system for both anatomic and reverse procedures, allowing for an elevated operating room experience. Throughout this webinar series, you'll hear from leading experts in the field who will discuss the latest research, clinical evidence, and best practices in shoulder and elbow medicine. Thank you for joining today, and we look forward to sharing our passion for innovation and helping you provide the best possible care for your patients.
Okay, that was awesome. Thank you. Again, so anyone who's on the webinar, please feel free to put questions in the chat. I'll be monitoring them and I'll get them to the panelists. For those of you who are on demand, if you ever have any questions, please reach out to any of us. We'll be happy to answer it. And you all are in trouble tonight. Joaquin's here. He's going to grill you. You don't have the young guys who don't know what we're talking about. You got an expert. So we'll get in. We'll get in with the first paper, which is going to be the one on distal biceps repairs and surgical timing. So this paper states that surgical treatment of distal biceps ruptures vary based on time of injury. They looked at 3 different types: direct repair, which is preferred for acute injuries, high flexion angle repair, and allograft reconstructions for more chronic. So the purpose of the study was to examine the relationship between time to surgery, surgical technique, selection, and complications. This was a retrospective review that was conducted on patients treated with distal bicep tendon from 2012 to 2023. Inclusion criteria was age of 18 with unilateral ruptures, demographics, time to surgery, surgical techniques, and complications were recorded. They looked at a total of 373 patients, which included 90% having a direct repair, 6% having a high flexion angle repair, and 5% having the allograft reconstruction. Time to surgery varied between the groups. For the direct repair, it was usually 16 days. For the high flexion angle was 82 days, and for the allograft reconstruction was 274 days. Surgical technique selection was significantly associated with time to surgery, with direct repair favored for acute cases and the other 2 for more chronic presentations. The inflection point for probability for direct repair, high flexion angle, and allograft reconstruction was about 25 to 27 weeks post-operatively, indicating more chronic repair. And the overall complication rate was 12%, with nerve injuries being the most common. So they say that timing of surgery directly impacts the surgical techniques between the different groups. And they found that there were not significant differences between the different groups. So maybe we could start with you, Matt Ramsey. So what are your thoughts on this overall paper? When I guess the question that I have for people who do a lot of distal biceps is, what's too much of a high flexion angle? What's your algorithm for more of the chronic ones?
Well, I don't know that we've defined what the limit is. I mean, the the aha moment was, we all know, or at least the literature when I first started was very clear that a direct repair was preferable to an allograft repair. So those were our kind of options. And so many of us who couldn't, and it's more the subacute kind of distal biceps ruptures where you could mobilize the tendon, but there was some contracture and you couldn't fix it with the elbow at or below 90 degrees, then you would try to flex them up a little bit to get it fixed because we knew the outcomes were better. And I can still remember going to meetings and having people be like, yo, dude, I fixed one of these at 130 degrees and, the patient did great. And what you invariably see, which is always kind of the interesting part, is that usually by the time of their first post-operative visit, you can get them out of that high flexion angle very easily. The muscle does come down in time. And so, so it really wasn't an issue after clinical experience showed it to be good. The question was, did they get all of their range of motion back? And they tended to do that. So, I think it became a very legitimate thing. And what this paper highlights, I think, which is kind of the value of this paper to me, is that high flexion angle repairs are a very legitimate way to fix these primarily, which is preferable.
And if you
Yeah.
go, sorry, go ahead, Mark.
Yeah, I think that we published a paper on repairing them in high flexion. Must be about 10 years ago now, and I totally agree with everything that Matt said. For some reason, we know muscle adds sarcomeres in series, so that's one thing to understand just from a physiology standpoint that they do that the biceps will stretch out over time, so they don't tend to get flexion contractures. Because that was a big question I had when I looked it up. I was on my dad's service, and I was like, we're repairing these things at like 120 degrees. Are they going to get stiff? And they didn't. And it's strange because the flexors are so much more powerful than the extenders, than the triceps, but they still seem to stretch out. So just as just further validation of that. But I remember the reason that I asked him about that was it was so hard to close the wound. Like we were way up here like this. And so one thing that came out of that is, fix the, get past all your sutures and everything, just from a technical standpoint, get everything ready and then extend the elbow, close the front incision, and then flex it up when you've got the posterior part exposed, because I remember that vividly being a very challenging thing to do if you forgot to do that. I would love to be able to tell you that I haven't forgotten to do that since, but it has happened. So the only time I really use graft anymore for me, and you guys can chime in, but is really when there is no tendon. So it's just a muscle, and you've got this little nubbin and you're hunting around. And sometimes you can peel open the scar tissue and like deliver this rolled up accordion like tendon. But not always. And depending on the chronicity, sometimes it's just nothing there. And in that case, then I'll use a graft to get it down. But otherwise, I would very much favor high flexion repair.
So it's interesting you mentioned that. I cannot remember I won't even say acute. I cannot remember a primary rupture that I've used an allograft for. Most of my allograft reconstructions are for a failed primary repair that's then re-ruptured. That's typically my algorithm as to when I'm going to shift to an allograft.
Yeah, so revision or or you can't. I remember one I had to use an allograft for recently, the last year. It was 8 years after the rupture, and suddenly, it became, imminent that, he have it repaired. But it just doesn't happen very often.
One challenge, though, for the people that are listening and are younger is that, uh, in my experience, it's difficult to predict. Meaning,
Mm.
that if you have a patient that is undergoing surgery, let's say 4 months after the injury, let's not go extreme like 8 years, but also
Hmm.
2 weeks. I have been in situations where there was a tendon, as it is where there was not a tendon. So I always consent the patient for both. Maybe to go around the table, Mark, Mike, and Matt, do you guys have a threshold after which you say, I have to have a graft? Is that a month? Is that 6 months? Like maybe for Matt Ramsey, when is it that you say, just in case I'm gonna have a graft?
Well, I think Mark kind of brought it up a little bit for me. So I don't often get imaging if I see them acutely, but if they're subacute, I will always image them because I want to see where the tendon is. So some of these, the tendon just retracts straight proximally and it's in line and it's proximal. Those ones very rarely, I think, need a graft, even subacutely. It's the ones that recoil and kind of wind back, after 3 or 4 weeks, even if you can unravel that, so they all form a cocoon of scar around it, and you can tease the tendon out of that ball of scar. But very often, when you're teasing it out, the quality of the tendon, in my experience, has not been great. But the value of to me, the hardest part of allograft is always determining the length of the graft.
Mm.
How much is too much, how little is too little. And even if the quality of the tissue is not primarily reconstructible, you can at least use it as a determinant of length for your graft. That's the way kind of I do it. So to your point, so I will always, anytime after 6 weeks probably, I will consent people for graft. I will always talk to them about it and we have them available. And I think, it's probably not a bad idea to consent everybody for graft. I mean, just to have it on your consent and have the discussion, whether you use it or not, obviously that we can talk about kind of what are the indications to use it, and we have talked about it a bit. But I think you can be fooled acutely with tissue quality. That's been in an acute setting. The times that I've grafted an acute rupture is when you get in and you just look at the quality of the tissue, and it's just really not great tissue. And then I'll graft them even acutely. And then obviously anything for me over 6 weeks, then I will consent for graft
How about for you, Mike?
and have the discussion about what are the thresholds.
So
For
we're
you,
pretty lucky. We have most of these things. We do so many tendon transfers that we essentially have an Achilles allograft almost on standby for almost any of the stuff that we do. That said, sometimes we'll augment with a palmaris, meaning if the tissue quality is not as good, and as opposed to going to Achilles allograft, we may augment with a palmaris double over on itself to some degree. But that's if the tissue quality is not great and we're worried about what you're getting into, which remember, right, this is a tendon that ruptured. So oftentimes there's going to be something wrong with the tendon, at least the distal stump, or as it inserts. And then, I think what I'm finding now as I've gotten further into practice are these high partial tears where these people come in and they've torn a significant portion of their tendon. They're not fully retracted. They've torn a portion of it. And we now know that both heads technically insert onto the radial tuberosity, but you see these partial tears now, they're high grades. They've got a lot of fluid up the bursa, and you try and treat it non-op, but they all come back with persistent pain. I just have not had a great experience treating even the high grade partials without surgery at this point.
and maybe for
So
you, Mark, a question that came through the chat. How do you rehab the patients that you repair in high grade of flexion? What's your protocol, Mark? Like let's say
Yeah.
you feel the surgery and the patient goes to 70 degrees. Then
Yeah.
what?
So what I do is I put them in a sling, very quickly I tell them, post-operative day 1 to make sure that they're rotating, because I do a 2 incision repair. I think that's important for people to know. I don't do 1 incision. So I think it's important for motion, particularly pronation and supination. So I make them do that. I tell them every commercial break typically. But several times a day, I want them pronating and supinating, even if they're using their other hand. And then I want them to come out and let gravity just let the arm hang. So they come out of their sling, 6, 7 times a day where they just let their arm hang. And that's really it. I don't put them in a brace or a splint. I did early. I put them in a brace and then, marched it out. And then I was talking with Sean one day and he's like, don't do that. Just keep them in the sling, have them come out of the sling, use gravity and they'll stretch out. And he was right. So I think, not, at about 3 weeks, then from the time that they can get their motion or they can get out straight, then I start eccentric strengthening exercises. So that's my typical protocol for the acute ruptures that don't need high grade, high flexion repairs. As soon as they can get straight, which is typically around 3 weeks or so, then I'll let them start doing eccentric strengthening for the rehab.
Perfect. Okay, awesome first discussion. Joaquin, you will go into the next paper?
Sure. So my paper to discuss with you guys first is the one entitled "Does Timing of Total Orthoplasty After Distal Humerus Fractures Affect 2-Year Complication Rates?" This is by Joshua Schwartz and Brian Werner and others from Charlottesville, Virginia. And this is a Pearl Diver study, so it's based on a large US claims database. They report on 1,400 cases approximately. And they are divided in 3 groups. What they call acute is under 14 days. Delayed is from 2 weeks to 6 months, which we can argue, if a 3-week total elbow is still acute or not, but that's how they define it. And then salvage is a patient that had the total elbow 6 months after the initial injury because of failure of fixation, malunion, non-union, or post-traumatic OA. And the main outcomes are complications. Of course, with a Pearl Diver database, there is no patient-reported outcomes. So they looked at infection, triceps failure, revision, periprosthetic fracture, and wound complications in general. And there is a fair amount of acute fractures, about 800 almost, much less delayed, 200, and about 400 salvage. And as expected, the acute group were older patients and more females, because I think that surgeons have a lower threshold to offer an arthroplasty acutely to a female that is older. And they basically compared, using bone Ferrone correction, 2 groups, acute versus delayed. So patients that get the operation the first 2 weeks versus 2 weeks to 6 months. And they found that in the delayed, there was 2 times higher rate of infection and 6 times higher rate of triceps injury. Which I want to ask you guys, because typically when I do a total elbow for fracture, I don't touch the triceps, so I don't fully understand it. And then the second comparison is acute, so 2 weeks after the injury, versus salvage, which is anyone that already had ORIF or 9 months have gone by and there is a non-union. And they found that the rate of revision was 3 times higher. The rate of fracture, either ulnar or humerus, was 3 times higher. The rate of infection 4 times higher, and again, the rate of triceps injury 5 times higher. So we can start maybe with Mike. Mike, how do you factor in this information in your practice today? Like if you have a patient with an acute distal humerus fracture and you're deciding if it's better to fix it and if it fails, do a total elbow versus just go with a total elbow and these complication rates, what's your take?
So it's very interesting, right? So we have a large level 1 trauma center where we are, and I have a lot of partners that fix distal humerus fractures, tend to be in younger, high energy trauma. Myself and Eric tend to do a lot of the older patients that come see us. It gets a little bit challenging on your decision making. The fracture pattern plays a huge role in whether or not I will fix it or not, obviously. We're obviously talking mostly intra-articular fractures here, 1-3C type of injuries. The ability for me to fix it depends on a couple things. If I feel like I can really reconstruct the trochlea well and get a stable elbow afterwards. And then part of me thinks of, I do a fair amount without having to actually do olecranon osteotomy. It's not saying I don't do olecranon osteotomies. I just try not to in the older population, knowing that there's a high chance that I will come back. Now, even when I've done one, I've converted patients down the road to total elbow. It just makes me a little bit more cautious when I'm obviously going there. But to your point, if I'm putting a total elbow in a patient that has a distal humerus, there's no reason to touch the triceps whatsoever. So the only reason why there would be a triceps issue, in my opinion, is if this person's already had a prior RIF and someone has done something that they, either electron osteotomy or something, and now you're trying to have to figure out what you're going to do to work around it, or there's so much scar. But I think, to Mark's point earlier, part of it is for those people that really understand the elbow and understand the anatomy of what you can get away with, what releases you can get away with around the elbow, that makes a huge difference for exposure. And I think that's often why most people struggle, is because of inadequate exposure during RIF or inadequate exposure during total elbows. So I think once you understand how to get to it and you can get to all the pieces reasonably, then you can decide. Now, if their bone is mush, you're kind of hosed either way. And then you're like, look, this is what I'm going to do. And so it's just like everything else. You have everything available. You can send them for both and say, look, I'm going to take a look while I'm in there. And if I feel like I can give you a good outcome with an RIF, this is what I'll do. But I think ultimately speaking, the outcomes for both are really good when they both work. The outcomes are bad for both when they really don't work. And then, you're kind of in the middle when you're just hoping and say like, well, look, you're kind of hoping things are going to happen. But look, I've salvaged many with a total elbow. But I think my biggest issue, honestly, has been aseptic loosening. And specifically when you're missing the condylar support, and then we have to go back in and do a allograft prosthetic composite, which has saved us, honestly. But that's a very powerful procedure, but it's a big whack.
What do you think, Matt?
Well, I think Mike's point is completely right on. I think most of these problems exist because people don't get adequate exposure, for sure. And for those of us who do a lot of elbow replacement and elbow fracture work for that matter, and spend a lot of time around the elbow, that I think these issues don't seem as daunting. But if you're doing one or two of these in a career or in a year, leaving the triceps on can be tricky in either of these operations. I would say I find it harder in fracture work, particularly the C3 fractures, to get good exposure of the articular surface. You can do it, but it can be tricky when there's intercondylar comminution or trochlear comminution. So, for me, I am a big fan of, listen, if you've been in this game long enough in the elbow, that nothing ruins a good result like follow up. And so
Oh, yeah.
if there was a time in my life where I put elbows in a lot of people who had these fractures that I didn't think I could reconstruct. And one of my trauma guys has a saying, and I don't know that it's original to him. He calls older people functional quadrupeds, because even though it's your upper extremity, they're bearing weight on walkers, they're using their arms a lot to assist with getting up out of a chair, and they put a lot of stress across the total elbow. And they do loosen and they do fail, and we all know that that's a tricky kind of recovery at times. So I've kind of shifted a little bit as I've gotten a little older and tried to fix more of these fractures. um, Now, that being said, when Mike is right on. When they go bad, they go bad. And when an ORIF fails, there is no doubt that the early literature on total elbows after trauma was that they did pretty well, that you could salvage them. But I think the highlight of this article that's concerning is that the complication rates are significantly higher in that group. So it makes you kind of reconsider where you go. And my goals in an older person with marginal bone are different. Like if I can get somebody fixed and they're a little older and their bone quality is good but not great, I'll lock them up for 6 weeks, because what I say to folks is I have an operation for stiffness that I can manage your elbow and give you a functional elbow. But if it fails, then the revision or the reconstruction down the line is a little trickier. So, I will tend to go slower in some of those folks. But for sure, I am trying to fix more of these than I used to. And, this article may make me reconsider that. I've got a few more years in practice, so anything I do now will not affect me. So,
But Matt,
you know,
yours don't fail. This isn't a you problem. You don't have to worry about it.
You know, Matt,
uh,
one good point you made is that because this is a pearl diver, it's community surgeons. Some people, as you said, may take the triceps down for a fracture, even though Mike was saying he never does, and I typically don't either. But other people may say, I cannot get it done otherwise. So that's a very good point.
well, and I think, we can talk a little bit technically too about how you do this. So we all use a a paraolecranon approach for these. Medially, you go off the medial side of the triceps, but what you do laterally with the triceps matters because if you use Coker's interval, which you can do, so the lateral triceps to Coker's interval, you have a lot of tissue there that you have to contend with exposure. And the problem here is, for me, is two things. One is getting the angle right for your ulnar component, meaning you're not at too acute an angle where you're going to violate the dorsal capsule or the subcutaneous border of the ulna, and malrotation, which when we talk about aseptic loosening, malrotation of your ulnar component is a big kind of implicated to some degree in that. So I go straight off the lateral side of the olecranon and take the anconeus with the lateral triceps laterally. And then I have a lot less bulk of tissue. And you still leave the triceps that's attached to the ulna attached to the ulna. So you still have the integrity of that, but you've debulked a lot of the triceps by taking that laterally. So, I think technically there are ways to do it. And listen, it is, even with the distal humerus out, um, you have to work on your exposure. And I think Mike was right. You learn the techniques to release tissues for better exposure so that you can get your implant in properly.
All right, we have a question from the audience. And maybe we could just go down the line because this is a simple one and it's fun. We'll start with you, Mark, then Matt, then Mike. How often are you consenting for both procedures? Do you know? Do you have both implants at the time of the first surgery? What's your thoughts on that?
Well, it depends. If you're really young, I mean, this is a bimodal distribution. So, you either have young, higher energy injuries and then older, fragility fracture kinds of things, or even insufficiency fractures for folks with pre-existing rheumatoid. I mean, I think the thing to remember too is that, Mark's dad's original article with Tyson Cobb on this, that the majority of those patients were rheumatoid patients. So it was really with the success in the rheumatoid population that we started to expand the indications to true acute trauma, like universally acute trauma. So if you're older, I mean, I always CT my distal humerus fractures now just so I can get a really good sense for what the articular surface looks like. If it's a simple T condylar fracture or a supracondylar fracture, I mean, I wouldn't be thinking about total elbow. But anybody over the age of 80, 70, 80, that I'm going to try to fix, I'm going to definitely consent for elbow replacement. If you're 40, probably not, because I'm going to do, and nowadays, I mean, that would be, this isn't germane to this article, but distal humeral replacement was something that I would consent a younger person with high energy trauma. That's a challenging thing to do now because of our FDA clearance of implants in this country. We don't have a truly anatomic distal humerus replacement. We can fudge some of the total elbow distal humeral components to work in a pinch. But a younger person, I'm going to really try to fix and probably not consent for total elbow. But if you're older and your bone quality is poor and you have a bad injury, then for sure I'm going to consent you.
So Mark and Mike, we could maybe answer that and then we'll go into the next article.
Yeah, I think it's hard. It's always hard because these are hard operations, whether you're going to fix it, and a hard operation if you're going to replace it. So I think, it's out of the gate. It's like, okay, well, if I only do one of these a year and I'm deciding, do I fix it, which is hard, or do I replace it as hard? That's it's a challenge, right? And so most people will go with what they um, what they feel more comfortable with. And the randomized controlled trial that McKee did and the paper that Matt talked about with Tyson Cobb, those papers were in skilled hands, with people that knew how to do total elbows and knew how to fix fractures. And that data, would suggest that, McKee's data, even in the long-term follow-up that Nilafar Dignan looked up the 10-year data on that, would suggest that total elbow is a wonderful operation in the older patient. And I think that's a bad term, older patient, because it's really about bone quality. Will the screw hold? Do you get purchase? And you don't really know that unless you've had some experience with, what is crappy bone and what is good bone. So sometimes it can be difficult in that way as well. But what that showed was that if a patient falls, it's a sign, and they break their elbow, it is a sign of that this is a fragile patient, because half of those patients died within the study period, but before the 10-year follow-up. So I think in the elderly population, the low demand population, it is a no-brainer for me to replace the elbow, because I know I can get that patient back functionally more quickly, and maybe prolong their life or quality of life than if I fix it and have to do a second operation, maybe for release, or potentially have a problem where they don't heal and then I have to do a total elbow. So I did a total elbow today on a 53-year-old who had an open reduction internal fixation that failed. Second time failed, became infected, and now he's got all this hardware in there that I have to take out and then stage for a total elbow. And I am telling you, the data that Nyla's looking up now, she presented some of this at the ASES. It is not free. So just like this study showed, if you do fix it, um, the complication rate goes up if you have to do a salvage, whether that salvage is open reduction internal fixation reunion of a non-union, or conversion to total elbow. It's just a harder operation. It's a longer operation. You're dealing with hardware, scar tissue, your complications are going to go up. So my dad used to have a saying, the best time that you have to do an operation is the first time. So, your point about when do you choose, I try to make an educated decision, about this fracture type. If it's a C3 in an elderly patient, that patient, for example, is going to get a total elbow. And a young patient, as Matt said, I'm planning everything to try and fix that patient, um, but have something as a backup. But I think you have, your best crack at this is the first time you do it. So don't think, oh, I'll fix this, and if it fails, I'm just going to do a total elbow. That's not the way to think about it.
Yeah.
Like,
I'll be brief. I know you guys probably want to go on to the next article, but I
No,
will tell you, I think Matt and Mark had very profound things. Couple things of what I would reiterate. One, any of my patients that have significant intra-articular comminution, 3D CT scan.
Oh, yeah.
That is what I would consider almost the gold standard now for like arthroscopy of the elbow, for fixation of really bad intra-articular fractures. It gives you a very good idea where all the fragments are, what the locations are. That has a significant, it's played a significant aid, in my opinion, to help determine, can I fix this? How big are the pieces? How bad is the trochlea really bad? Is it so comminuted that I can't get fixation? If that's the case, then I think, you look, I think the next is age, right? And it's not just age. Sometimes it's frailty, modified frailty index, all those things that we've reviewed over the years. I think long story short is if the patient comes in and they're 60 and they look like they're 80, gives you an idea. I will say the people that I tend to fix, no matter what it looks like, sometimes if it's a really bad open injury, I'm not going to put a total elbow in. If the patient's morbidly obese and I know that they use their hands to get up off of the chair every time, not going to do it. And if they're, I use the term quad ambulator. If they're using all four limbs to get up and walk, they're not going to get a total elbow from me either. That's my kind of rationale.
great. All right. That was awesome discussion. And I think everyone's really looking forward to this next article, because I think most of us don't know what the anteromedial coronary facet fractures are and don't treat them. So I think we're all looking forward to your commentary on this. So title of this paper is Anteromedial Coronoid Facet Fractures with Associated Injuries Have Inferior Outcomes associated fractures and clinical outcome comparison. This was from our good friends in London, Ontario, again, pioneering elbow literature. They looked at various posterior medial rotor instability that results in anterior medial coronoid fractures with associated radial head fractures or elbow dislocations. The objective of the paper was to compare postoperative patient outcomes of AMC fractures with and without radial head fractures and elbow dislocations. This was a retrospective review of patients who underwent operative fixation of AMC fractures at 2 academic centers. Inclusion criteria included 18 years of age who sustained AMC fractures with or without elbow dislocations or radial head injuries. The primary outcome was Mayo Elbow Performance Index. Secondary outcomes were joint congruence, range of motion, complications, revision surgeries, incidence of HO. They had a total of 61 AMC fractures that met the conclusion. Average age was 44 years old. Average length of follow-up was 23 months. Demographics were similar between all the groups. 32 patients had no concomitant fractures. 29 had either elbow dislocation or radial head fracture. They found that the coronoid subtype and fragment size did not differ between the groups, and postoperative mean Mayo Performance Index scores were significantly lower for patients with common injuries. They found that patients with common elbow dislocations or radial head fractures had significantly less flexion and supination in follow-up, and a significantly higher incidence of HO and higher grade HO. So this paper was an overall great study that concluded that complications and outcomes were worse with associated fractures of AMCs. So, Mark, maybe what does this paper mean? I think a lot of people want to know, like, how do we see these fractures so rarely? What's your big
Yeah.
take?
Yeah. So first of all, to everybody that's on the call, I would get every single thing that Armin Badri has published on the anterior medial coronoid, and I would read it. The guy has really done a masterful job of demystifying the anteromedial coronoid. Can you see my camera? So this is the view that you need. Can you see the coronoid?
Yeah.
This is the view you need. So I've drawn a couple of different things on this model. The anterior medial facet, it's the crescentic shape. And what happens is the humerus, the medial side of the trochlea, drives through the anterior medial side. It's like a die punch injury, and it's almost a perfect cast of the anterior medial trochlea. So you get this crescentic shape, and that's the view that you need. You need a subtraction CT view to really understand it. And it's commonly missed because commonly the radial head is intact. Now, what this paper shows, interestingly, is that they had about half of their patients that had an associated radial head fracture. So they were likely categorized as a terrible triad. It's got a coronoid, it's got a radial head, right? It's a terrible triad with some degree of instability, but the pattern is different. So the location of these fractures is different. So even the radial head fracture is oblique, and it's slanting medially rather than slanting laterally, rather than it being the anterior lateral surface of the radial head. It's the medial side of the radial head, and it just carried through with a little bit less or more flexion to also break the radial head. But it's a higher energy injury. So you're going to have more of those secondary complications. You're going to have a greater degree of instability, although they didn't see that in their study, but a greater degree of HO, which I can, if you've got a posterior hip dislocation that's smashed, that also has a greater degree of HO. So the higher energy fractures have a higher degree of complications. And so I think, what this paper really highlights is the coronoid is king, and you have to recognize that pattern where the crescentic shape of the coronoid, because that may dictate how you fix it. So it may not be all from a lateral approach, although I think you can do it that way. But sometimes you may choose to do a lateral approach for the radial head. You may choose to do then a medial or extended medial, which is my preferred technique for that fracture, approach on the medial side, and just give yourself permission to see the fracture so that you can fix it right. The one that really, really matters is that anterior medial facet. And I think that the coronoid is secondary. We've got lots of biomechanics studies that show that if you don't have a coronoid and you lose your radial head, you don't go nowhere.
Right.
If you've got a coronoid fracture and you resect the radial head, please don't ever do that. That's also a loser. But I think it's recognizing that pattern is just absolutely critical to the treatment of these. And that's your approach, and that's how you fix it, and understand, okay, what is my goal here? And that's really to restore ulnohumeral congruity. And that's done with both the anterior medial facet and the radial head. So we could talk about technique and whatnot, but I feel like
Well,
we've already
I
kind of
just like
covered
to
it.
add something which I think Mark hit on, which I think is really important. We've tended, I'm in this game long enough that I've seen this evolution happen. And, it was all terrible triad injuries. The original Reagan-Mori classification of coronoid fractures was axial plane fractures. And I honestly do believe the advent of CT imaging acutely has really changed the thoughts. Somebody was smart enough when they were looking at these fracture patterns three-dimensionally to say, this is not
Yes. Yeah,
what
it's just different.
this is different. And, for a longest time, we never even recognized the anteromedial coronoid injury. They would often go completely unnoticed with horrible consequence, by the way. These
Right.
are really poorly tolerated injuries if they're missed. So, and then we started to recognize them, and then it was like, okay, there's this whole separate series of injuries that are varus posteromedial, kind of, where you have an anteromedial facet, you have tensile failure of the lateral side, no radial head fracture. And what we're seeing now, again, is we're refining our kind of understanding, is that this is a spectrum of injuries that you can't really classify in two distinct piles. They are subtle. And I think, to the point that Mark made, imaging is really important. I mean, if we thought this was important in our discussion of our last article with distal humerus fractures, I would not go to the operating room with one of these injuries without a three-dimensional CT scan.
Mhm.
With subtraction, if they can do it. It obviously aids tremendously in your diagnosis. Because again, Mark lived with his dad for a long time. I lived with him for a few months when I was training, and his saying was, you go nowhere without a competent ulnohumeral joint. You just do not. It doesn't matter anything else you do if the ulnohumeral joint's not congruent, and it needs to be perfect with these anteromedial coronoid injuries. You can't accept anything but perfect. So yeah, that's to me what this article said, was that there are subtleties here. They are not distinct piles of injuries. It's along this spectrum, and you better get it right for sure.
Yeah, I mean, we don't live with our elbows, at our sides. I mean, everything we do is out away from the body. And the anterior medial facet is going to buttress that. So if you don't have it, you're just going to fall into this incongruent pattern. And it's just a setup for just an absolute raging horribleness. And it goes very rapidly.
Yeah.
So some of these patients, they'll show up and it looks like a rheumatoid change, and with just this effaced medial side of the joint. And then you're wondering yourself, well, there's huge osteophytes, and that was just missed. It was just a missed. It was just a missed anterior medial facet. Now, those are subtle. If you've got one of the positives, if you've got a radial head fracture, usually you're not going to miss the fact
Yeah.
that you also have another fracture, particularly if you get the CT scan. But what happens a lot of times is the radial head is intact, and you look at the AP, and then there's just this effacement of the medial joint line, and you're like, well, what's that? That's curious. But that is you got to have your antenna up. You got to say to your radiologist, or to your resident, get a CT scan, because that's an anterior medial facet. And so you just really have your antenna up when you see that type of condition, particularly on the AP X-ray. Just effacement of the medial side of the joint. Something is off there.
Maybe two quick questions for Mike that came through the chat. So, Mike, do you ever use fluoro to check if this fracture needs surgery? And the second is, what is the role of a joint stabilizer, like the IJS, in your practice?
Mm.
Yeah, someone obviously knows me because I use it a lot. That's probably why. So look, so fluoro for me, right? I don't take these fractures to the operating room and fluoro them to then decide whether or not I'm going to fix them. that to me is done in the office typically, and how stable they are, whether or not they were dislocated, whether or not, what motion I can get them to do in the clinic at that point in time. Because once I've taken to the operating room, I'm going to fix them, and that's for me. The IJS for me is very interesting. I should just mention this. I have no actual disclosures. Our institution receives fellowship support from Skeletal Dynamics, but otherwise, I personally do not. So I just did one of these on Friday, and it's probably one of the worst injuries I've seen in a very long time, where the entire anterior medial facet was actually sitting in the cubital tunnel, essentially, with the articular surface, and the MUCL was off, at least half off. The anterior band was in, the
Good
posterior and
news.
transverse band were all off. I mean, it was
Good
a
news.
bad injury, and the LUCL was also off. So this was a dislocation with an anterior medial. I will tell you, I started with a posterior incision. I went directly, and I essentially lifted all the entire flexor peroneal mass off, and I essentially transposed the nerve, and I put a coronoid plate on. And my decision to go lateral was before I even fixed the anterior coronoid, or the medial facet, and I'll tell you why. My issue with these, when you're trying to fix very large ones, or when the joint is exceedingly unstable, just getting the joint to stay in stable enough to put the plate on is very difficult, right? I mean, you're futzing and then it moves, and then the plate is, the plate, these are small pieces. You have a hard time getting your angle. So I went lateral. I put an IJS on. It stabilizes the joint immediately. It's expensive, so it's not like it does a quick fix, but essentially it stabilizes the joint immediately from the lateral side and allowed me to work medial with no issues.
Well,
And
let me push back a little bit, Mike. So what about why not just fix the ligament then?
So we
Why
did. No, we did. I did everything. I fixed all of it. I fixed the LUCL, the MUCL, and that. Part of the problem is, the MUCL can be attached to some of these pieces.
Oh yeah, for sure. Especially if it involves a sublime tubercle, it's always there. But why not, rather than do the IJS, why not fix the lateral ulnar collateral ligament and then go, stabilize the lateral side and then go medial for your fixation? I find that, no, I'm not throwing
No,
shade here, but
it's a great
I have
point.
chased my tail, and then it's not until you've got one side sort of stabilized that you can, reliably work on the other
Yeah.
side.
So part of my rationale for this is I can let them move the next week. And, anxiety free. I am OCD about complications. I'm sure most everyone is on, but
Mhm.
it's funny. When our fellows graduate, and I always tell them, you have no idea until you're in your first year of practice, and the number of phone calls, and the number of phone calls that I get from our various fellows over the years, it goes up and up and up as they start practicing themselves and they start seeing their own complications. Um, I have never, what I will tell you is, I have never regretted putting an IGS in. Now, that doesn't mean that they always fix everything. Let me be very clear. Just like anything else you do, it has to be perfect. The access pin has to be perfect. And you have to know what you're doing with any of the implants that you use, whether it be an IGS or any of the plates that you put in. But I will tell you, having seen a fair number of the coronoids fail over the years because of improper fixation, or because of how much you're asking for such a small piece to hold into the elbow, it is a lot of stress over a small area. And I don't think our fixation to this day is still adequate enough for what we do. That's my personal. Now, I won't say I fix every single coronoid, but if I'm going in for a terrible triad, I fix every single coronoid. But I also use the Wrightington classification, and that's what I typically go off from Adam Watts.
Mhm.
And that's taught me a lot about the patterns of the elbow. But I mean, if you look at the number that they fixed on this over, I think it was a 15 or 20-year time span, they only had 60 that met this criteria.
Mhm.
So you're talking like 3 a year or whatever it was. Now they had more than that, as far as like they had 160 total coronoid fractures, but those that had concomitant injuries, you're only talking 60. That's 3 a year, and that's by expert. These are by expert master surgeons. So
Mhm.
I always tell. I mean, it sounds bad to say this, but if you've never fixed a coronoid, these are not the type of procedures I think you should be doing. This is something that I tell you to refer to an elbow expert. These are for me, coronoid fractures and glenoid fractures are the hardest fractures in the body to fix.
All right, this has been awesome. We got 9 minutes left for last article. That surpassed all expectations for that article. Great job. Joaquin, you want to do the last article?
Yes, so this is an interesting article because one goal of the journal club is to see if there are some papers sometimes that are somewhat weak, and I think this paper has some weaknesses. It's a bi-center study, so this is a group of patients that had surgery in Boston and in the Netherlands, basically. and it combines 161 elbows that had all radial head fracture, and they're divided into two groups: people that were younger or older than 40. And then within that group, they divided it into the ones that receive an radial head replacement or internal fixation. But the groups are very unbalanced because of the 161 elbows, 96, almost 100 of the 160 were arthroplasties over 40. And then there is 32 arthroplasties under 40 and only 22 ORIF. So I think that the imbalance makes it difficult to make comparisons. But when they looked at the difference in reoperation rate, if you take all comers comparing radial head versus ORIF in any age group, the reoperation rate was 16% after arthroplasty and 18% after ORIF, and there was no difference. When they looked at younger patients, the reoperation was higher after radial head, 22% versus internal fixation, 14%, but with these numbers, the difference was not significant. So the only two findings that were significant were that if a patient is under 40 and gets a radial head replacement, there is more X-ray arthritis. But the X-ray follow-up is between 7 and 12 months.
Yeah, that's
But
my
then
problem with it.
with that follow-up, you cannot really judge if the elbow is arthritic because at 7 months, things are still healing. And then in the patients that had a radial head replacement, comparing under and over, the only difference is that there was a higher stem lucency in older patients. And the difference wasn't that much. It was 53% versus 67%. So I would argue that this paper, from my opinion, and I respect the authors very much, maybe doesn't change much what I would do because it's so imbalanced, and it's interesting to see how it did make it into the peer-reviewed literature. But I don't want to be too critical, but I'm open to what thoughts you guys have about papers like this that maybe don't add as much to the literature.
I mean, I don't want to throw shade either, but to use the vernacular of the kids today, I did think it was mid. I'm not saying that it was an outstanding paper, and for the reasons you brought up. I mean, to to break an elbow is actually the force required to do that is higher than the force needed to knock off cartilage cells. So we know that. So we know that there are well described studies that have impact loading to generate arthritis, and that's under that which is necessary to break the elbow. So we know that these patients are going to develop post-traumatic arthritis, and there is not a dramatic difference. And the timing, as you said, is not adequate. I mean, a 7-month radiographic review, I don't think is an adequate time to determine the differences between those groups. So I'm not sure that it's going to change much of what I do in my practice either, Joaquin.
For you, Mike, do you find yourself doing more RAF, more arthroplasty, a combination in your practice? What's the breakdown?
So it's interesting, actually. As I've gotten further along in practice, I'm actually fixing more as opposed to replacing. Now, I will tell you, I tell the residents, I tell our fellows, replacing it takes 2 seconds. It's a much easier procedure. That's why the vast majority of people like to do it, is because, just like everything, you can follow the money. It's relatively speaking easy. You have a rep there that's willing to sell you a replacement. And it's a much faster operation.
Or
If you-
fixation.
Yeah. But
So-
I will tell you though, also you excise it. If this is a terrible triad, you excise it. You have easy access to a small coronoid if you want to fix it from the lateral side, if it's a small coronoid to fix too. So people do that. Now, I will tell you, I've started fixing a lot more of them solely for the fact that you start seeing all the complications that go with radial heads. Now, that doesn't mean that ORIF can't, there's not complications either, but this is one of the things where this is not hard to have all of the options available at the time because they often come in the same set, regardless of which company
Right.
you choose to use. So you often have all those things and you can evaluate at the time, well, how big are these pieces? Are the pieces large enough? Can I get access to them? Do I need to put a plate on, headless screws, all this stuff? But yet again, I think it's just like everything else. It's often exposure. People don't get enough exposure because they're worried about the posterior interosseous nerve. They may not go find it. And it's one of those things where I found myself fixing more of them solely for the fact that if they do heal, I think that you will get a much longer life out of the patient's elbow than if you replace it. It's interesting. I actually just took out a silicone radial head arthroplasty that's been in for almost 20 years,
Wow.
and it withstood the test of time. It did break. It's interesting. It broke at the head neck junction, but looked pretty good, all things considered.
The scholastic radial head implants create massive synovitis. So that is a well-known phenomenon in them, but they did work at least for a period of time. I think it's interesting because, Matt, I'd be interested to hear your thoughts on this as well, because, the patient that breaks their radial head, say they're in their 40s, and we say, oh, we're going to do an implant, and we put in a radial head implant, we would consider 20-year data to be incredible data. I mean, it's like, wow, that's so long. But that patient's now, if they're in their 30s, is now 50.
Yeah.
And I'm 50, and I would consider myself a very young man, you know? So
It's funny, the older you get, how
It's
important the
it's
number is
all
younger
relative.
and younger.
it moves, doesn't it?
Oh, sure it does. I mean, so, I'm a very simple-minded thinker. Like, I think if you can fix radial head fracture, the tricky part to me, so the displaced type 2 radial head fracture is a no-brainer. Those are easy to fix, where you have a pedestal of intact radial head and neck to build to. Those are easy. And I don't think there's any discussion. I mean, there's discussion about whether you fix them or not nowadays, but if you make the decision to fix, those are a chip shot. Those are, very simple to fix. The ones for me that are always challenging, and it's not a matter of time. I mean, we're all pressed for time and all that stuff, but to me, it's making the decision about what's in the best interest of the patient. But if you have a smashed radial head, I think probably um, the best classification, or the most intuitive classification, was Bob Hotchkiss talking about reconstructible and unreconstructible. And to me, that divides it into, if you can fix it, fix the damn thing. If you can't fix it, replace it. So, I am not a guy who brings parts to the back table and puts them all together. I mean, I will do that, but I've always found that getting the radial head put anatomically on the neck and shaft, or the neck, is really difficult, or more difficult in that scenario. And you get a lot of subchondral impaction in some of these more difficult fractures that I've found put you at risk for non-union, or at least the need for me to bone graft those acutely
And
from the
Matt, can you hold that thought for 1 second? Joaquin has to log off. I just want a special thank you to Joaquin for joining us. Thank you for everything, Joaquin. I know you have a million meetings tonight. So Matt, sorry, go ahead.
No, that's okay.
Yeah.
Gotta love the elbow, Joaquin. Um, so, so I don't have, I think the challenges that patients have had with radial head replacement when they're younger is they're oversized. And for sure, if you have injured cartilage on the capitellum, which I agree with, every single one of these patients has some injury to the cartilage, whether you see it and recognize it at time zero, or it manifests itself down the road, it is there. And we all know that contact pressure, if you oversize the radial head, goes way up, and that can be a problem. But properly sized radial heads, I'm much more worried about the lucency issue than I am about the arthritis issue. There are a couple of concepts in radial head replacements that I've always found interesting. One is the right medical radial head philosophy that's Graham King designed, which is you just float the stem, and it's not like you undersize it by 4 millimeters. I mean, you undersize it so that the head component can find its place on the capitellum. And then there are the more rigidly fixed, so where you press fit the stem. And to me, again, if you don't get rotationally things right, then you're creating a whole different issue with the way that the radial head implant kind of tracks on the capitellum, which I've always been interested in.
Yep.
So I've always favored the one where it just kind of finds its place, and almost all of them develop some lucency. and I have, and I'd be interested in if Mark or Michael or even Chris, have an idea. Like there are some people who develop a little bit of lucency and then it stabilizes and nothing happens beyond that. And I just took a radial head out of somebody who literally lost the entire proximal radius. I mean, it just disappeared. And I don't know if that's a mechanical phenomenon. I would imagine it is, but I don't understand why some people have that clinical presentation and others don't.
Yeah, so we looked at 3 different implants. It was over 100 different implants in each group. And the Right Medical, which is made, as you said, to be a spacer, um, performed equally to the Acumed radial head implant. So both of those at long-term follow-up, and our average follow-up was 8 years. So I mean, maybe that's not 20 years, but it's pretty long-term. That was the mean. So you're getting into a decade and it's still performing. I think that's what it's going to be. So I think that it doesn't. I think it's dealer's choice. And I have vacillated between the two. I think a well done anatomic has some theoretical advantages that haven't yet been borne out in the literature. And those theoretical advantages have to do with the bearing, how they load the capitellum. But
Mhm.
but again, this goes back to, well, we know that there's some capitellar problems at the time of the injury because it's the impact load. So are you going to stave that off with a more anatomic design? That remains to be seen. So we don't know that data yet. So I think, having it well sized, and you can have it overstuffed medial to lateral, so it can be too large of a head and impinge with the proximal radial ulnar joint, or push you out laterally and then you get some loading that's abnormal, or too long. And that's historically what we all think of as overstuffing, is just having it too long. And that happens because the collateral's off. So you try to get stability, but you can never get stability because the collateral's off, and you just try to do it with the implant, and that's how those fail. So I would, read uh, the Graham's paper on looking at, and George's paper on looking at the proximal radial ulnar joint to get your sizing, but just reduce the joint. Just push your thumb up against the ulnohumeral joint, and then that gap then is what you have to work with, and because the collateral is off. So I would say you really have to get that part right, regardless of what implant you're using. But a well done anatomic and a well done uh, uh, non-anatomic or axisymmetric smooth stem perform the same. As far as the loosening and this expansion of the radial head, the SBI, or then it became um,
Striker.
Striker. Yeah, at the end it was Striker, but it was Avanta, then it was
Yep.
SBI, and then it was Striker. But that one had a design that um, my dad, for example, cemented that, even though it was a press fit. But if you press fit it and it got loose, it became a rasp, and so it just toggled around in there and created massive osteolysis. And most of the stems that are made to be press fit that don't get ingrowth early end up doing that to some
Mhm.
degree. And the Evolve, which is not meant to do that and isn't cemented in or isn't fixed, doesn't do that at all. It sort of reaches a stable uh, 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 position. So I agree with everything you said, and that was our data. So I think it's most of the time people who understood how to put in a radial head replacement were doing the anatomics or the Evolve, and there was no difference. So I guess we could wait another 12 years to have 20-year follow-up on some of those patients to see if there is a difference. But right now, I think it's really theoretical, and I would use the implant that you feel comfortable using.
All right, Mike, bring us home. What are your thoughts on?
Look, I wish I could tell you I knew it all, and I've used all 3 types of implants. I have no idea why all 3 have issues at some point. Part of me just says you do whichever ones you feel comfortable, whatever system you like for the other issues that you're fixing around the elbow typically. So if there's other things that you're doing at the time. Um, I don't have a great, as I said, I don't have a great solutions to tell you why things go south. I know that the axis of rotation around the radial head and the capitellum out to the ulnar styloid is more oblique and more different than I think most people think. How the radial head sits is a little different as well for a lot of folks. And even though we think it's anatomic, it's still not as perfect as we would like. I'm not sure how much the radial capitellar wear is as big of an issue as people think. I agree with you. I think the loosening to me is, when it is problematic, it can be an issue because to your point, the osteolysis can be dramatic, but then some stabilize and everyone gets worried. They send them to you. I'm like, look, we're going to watch it, and we watch it and we watch it. And I have people that are several years out and they've never progressed past where they were. And I say, look, we're going to leave it. We're not going to do anything. Then for whatever reason, something magically hits years down the road and they're like, well, now it's all of a sudden painful. I don't know why that happens or what that reason is, but I can tell you, what I've learned now is the patients that have a resected radial head that I thought did really well, they do really well for a very short period of time. And then they come back with arthritis on the medial side. Or if you're putting in a total elbow, they come in with aseptic loosening because you're essentially loading the ulnar humeral joint too much. So I've changed my thought process and the mechanics of the elbow substantially over the last several years of what I'm willing to tolerate, what I try and fix, and those types of things.
You guys are awesome. What a great journal club. You guys make elbow cool. Please go to Mark Maury's.
Yeah, seriously, it's gonna be fun.
Yeah.
It's gonna be super interactive. We're gonna do a lot of cases, and I'll bring some models, and people can play with the models. So, but we really want to make sure that everybody has the ability to come and learn and be more comfortable around the elbow. That's if you're comfortable around the elbow, then you can see around the elbow, then you can usually fix these things. And just knowing a little bit, I think is really helpful.
It was the first. We've never had a paper called a mid before, which is why Mark Moore is so cool. But like
Yeah,
John
yeah.
Chalk and Matt Ramsey too. I mean, I had to look that word up, so that's how lame we are.
I get that from my kids. I get that from my kids. And if it's really cool, it's fire. So this course is going to be fire.
Well, thanks everyone for joining us. Matt, Mike, and Mark, awesome journal club as always. That's why you're a recurring guest for Elbow, and thank you all for joining us who are in the audience. We'll see you in 3 months for the next journal club, and hope everyone has a nice evening. Good night.
Thanks for
Thanks,
having
guys.
us.
Yeah,
Thanks,
thanks,
guys.
guys. Good seeing y'all.